Hi, good evening. Sunday evening. Let's solve another question for the ADC written exam. And this is a very interesting question, interesting and informative question. Usually, you don't see so many TMJ patients in your general dental practice, especially when you are an intern. Very rarely you'll see, and the only thing you do is I think you just see here if when the patient is opening the mouth, if there is some abnormality or there is a profound clicking or something, and even if you find that, you refer to the postgraduates or you call your professor and hand over the patient, right? You actually never fabricate a splint. You don't know which splint to fabricate. Detailed chapters are given in the oral surgery textbook, but it goes out of your head, right? At least it did for me. Because when you don't do things practically, it's very difficult for you to understand, analyze, and since you don't see such many cases in the practice, uh, your brain just doesn't know, even if your eyes are seeing it. Yeah. But of course, TMJ forms a very important part of our lives, and even if you have to refer a patient to a TMJ specialist, you should first know what problem is actually happening. So, basic knowledge you should have. I don't expect you to have very profound, advanced knowledge like the postgraduate students or you fabricating a world class splint for the TMJ patients. But at least you should know what is happening so you can give a basic information to the patient if you have one. But TMJ questions are definitely asked in the ADC exam. And I'm not saying you need to know in detail, but you need to know some concepts for you to answer the questions correctly, because these questions have only one sure short answer. It's not like the unmarked questions. I have not seen TMJ questions having multiple answers correct. Other questions, yes, but TMJ questions are usually one sure short answer, which means if you mark it properly, you have a good chance of passing the exam. You won't be confused. So you should know the concept. Now, before I start solving this question for all the newly passed out graduates or for those specialists who rarely deal with TMJ, and I don't want to confuse your knowledge. So, I'm just going to recap a little bit with a very good video that I found online about the anatomy of TMJ. What is the disc, and what do you mean by clicking with reduction, the anterior displacement of the disc with reduction and without reduction. So just watch this video and then we are going to come back to this question so that you are very easily able to solve it. So I want you to watch this video.
Mandibular joint, the TMJ, is the joint between the lower jawbone, the mandible, and the temporal bone of the skull. The TMJ is responsible for jaw movement and is the most used joint in the body. The TMJ is essentially the articulation between the condyle of the mandible and the mandibular fossa, a socket in the temporal bone. The unique feature of the TMJ is the articular disc, a flexible and elastic cartilage that serves as a cushion between the two bone surfaces. The disc lacks nerve endings and blood vessels in its center, and therefore is insensitive to pain. Anteriorly, it attaches to lateral pterygoid muscle, a muscle of chewing. Posteriorly, it continues as retrodiscal tissue, fully supplied with blood vessels and nerves. The mandible is the only bone that moves when the mouth opens. The first 20 millimeters opening involves only a rotational movement of the condyle within the socket. For the mouth to open wider, the condyle and the disc have to move out of the socket, forward and down the articular eminence, a convex bone surface located anteriorly to the socket. This movement is called translation. The most common disorder of the TMJ is disc displacement, and in most of the cases, the disc is dislocated anteriorly. As the disc moves forward, the retrodiscal tissue is pulled in between the two bones. This can be very painful as this tissue is fully vascular and innervated, unlike the disc. The forward dislocated disc forms an obstacle for the condyle movement when the mouth is opening. In order to fully open the jaw, the condyle has to jump over the back ends of the disc and onto its center. This produces a clicking or popping sound. Upon closing, the condyle slides back out of the disc, hence another click or pop. This condition is called disc displacement with reduction. In later stages of disc dislocation, the condyle stays behind the disc all the time, unable to get back onto the disc. The clicking sound disappears, but mouth opening is limited. This is usually the most symptomatic stage. The jaw is said to be locked as it is unable to open wide. At this stage, the condition is called disc displacement without reduction. Fortunately, in majority of the cases, the condition resolves by itself after some time. This is thanks to a process called natural adaptation of the retrodiscal tissue, which after a while becomes scar tissue and can functionally replace the disc. In fact, it becomes so similar to the disc that it is called a pseudodisc.
I hope that you have understood this video now about the anatomy of the TMJ. So the takeaway from this video, what I want you to remember is that in cases of anterior displacement of disc, when the disc is coming anterior to the condylar process, it can be with reduction and without reduction. With reduction is you are still able to open your mouth fully and close your mouth completely. Like the full movement of opening and closing is there, and there is a clicking sound that happens. In without reduction, the disc continues to stay anteriorly to the condyle and the condyle cannot move over the disc, and so there is limited mouth opening, which is called as a locked jaw. And that also can naturally resolve itself because the retrodiscal tissue can become like a disc and then the condyle can again move ahead. So 99% of time the questions asked in the ADC would be anterior displacement of the disc with reduction. So basically there will be a clicking sound, but there is full opening of the jaw. Now, if on both the sides there is anterior displacement with reduction, it means on both the sides the jaw can open evenly, like this. It won't be deviated just to one side because it's bilateral. So there will be clicking on both the sides. Now, if it's just clicking and there is no pain, there is full range of the jaw movement that is happening, you don't have to do any treatment. You can just wait and observe. There is no need to give any sort of splint or medication because it's asymptomatic. It's just clicking, there is no pain, okay? Many questions can be asked as to what splints can be given if there are other problems associated with this. Now, how to remember which splint can be given in which condition? I would say pause this video, go on to this video, my video, just type on YouTube Dr. Garima TMJ video, and I've explained you very beautifully in this video which splint has to be given in which condition. Write it down, and I've simplified it so much that it will be very easier for you to remember. Because at least one question would be asked on the TMJ anatomy and clicking, and at least one question will be asked on which splint you have to give in what condition. So both these things should be very much clear in your head. Another thing is that TMJ, though I understand its involvement of two bones, the temporal bone and the mandibular bone, but the area that you want to see and are concerned about is the discal area, which is a soft tissue. So always any x-ray that you have to take to do imaging of the TMJ, it would always be MRI. Do not confuse yourself that you're going to image two bones, so it has to be a CBCT or a CT. No, it has to be MRI, 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 and always MRI. Okay, for that matter, any joint, you know, even for the knee or the shoulder, when you want to see the joint, you actually want to see the disc or the tissues that are in between the two bones, and MRI is the answer for that. So, having understood this basic concept, and I assume you have watched the video by now for the splints. If not, pause this video, watch the splint video, come back. Now we solve the question, and you will see how easier it is for you to solve this question. Now, Mr. Shah is a 38-year-old patient who has presented to your practice with the chief complaint of clicking joints when he opens and closes his jaw. Okay. Mr. Shah has a cerebral palsy and is currently taking several medications to manage his condition. He also informs you that he wishes to discuss various dental related issues, including clicking joints. Okay. What is the keyword here, or rather I would say what is the absent keyword here? That is pain. There is no mention of any pain. There is no mention of the locked jaw. So because these two things are not mentioned here, straight away it's a case of anterior displacement of disc because there is clicking present with reduction. Okay, because pain is not mentioned, because locked jaw is not mentioned, you are at ease. Means it's gonna be a simple case. Okay, what is the most conclusive diagnostic investigation that you should use to reach a diagnosis in regard to Mr. Shah's clicking joints? OPG, ultrasound, CBCT, MRI. We just discussed it's MRI, okay? Your diagnostic tests show that Mr. Shah has bilateral anteriorly displaced disc. We were thinking about it, they have mentioned it here. So that kind of gives a check mark on your thinking process. What is the appropriate management for Mr. Shah? We just discussed, because there is no pain, there is no locked jaw, there is no mention of deviation of jaw. Do nothing. Literally do nothing. Options explain that no further treatment is indicated. I mean, you should keep on following up, but yeah, there is no active invasive treatment that is indicated. Provision of mandibular advancement splint. When is the splint given? Pause the video, watch my video, come back. Injection of botulinum toxin to the masseter and the anterior temporalis. Nothing is mentioned about the soreness of the muscle. They are not in spasm, so no. Manual manipulation to recapture the disc. You can't do that. It's not a locked jaw. Prescription of diazepam for muscle relaxation. No. You, first of all, as a dentist, should not be prescribing diazepam at all. Even if you have to take the consent of the GP. So this option by itself goes out of the window. Now, Mr. Shah has impacted wisdom tooth 4/8 as shown in the periopical radiograph, which you decide will need surgical extraction. Surgical. What imaging modality would provide the most valuable information when planning for extraction of Mr. Shah's 4/8? CBCT. Hands down CBCT. Don't even think of other options. This is bone and tooth related, CBCT, not MRI. During your examination, you notice that Mr. Shah's gingivae are swollen. You learn that Mr. Shah is taking several medications for his depression and anxiety apart from his medications for cerebral palsy. Which medication most likely relates to Mr. Shah's gingival hyperplasia? Barbitons. If there is a mention of barbitons, go for it. Sodium valproate is another one, but he's not having seizures. He's having cerebral palsy, but cerebral palsy sometimes can be accompanied by seizures. But in the order of medication that have the worst effect on gingiva, the barbiturates top the list. Phenobarbital, straight away. Diazepam has the least effect. Others also have some effect, but phenobarbital tops the list. This you have to remember. Write it down, please. Pharmacological effects of certain drugs you will have to remember. Okay, this is one of them. Mr. Shah is missing tooth 1-4 and wishes to replace it with an implant retained crown. However, there is evidence of active periodontal disease in his oral cavity. Mr. Shah insists on prioritizing the implant over periodontal treatment. What is the most appropriate way of managing this situation? See, whenever you have to do an implant and there is an active periodontal disease, it's a straight contraindication. Why? Because who's going to stabilize the implant? The periodontium. What is periodontium? It is your gums, it is your PDL, but of course implant will not have the PDL. So, but I'm telling you the components of periodontium. It's the cementum, it's the bone. Okay, now when you place an implant, you want the bone to osseointegrate. If the bone itself is not healthy and is having a disease, is it going to result in a very beautiful osseointegration that you want? No, it would straight away lead to an implant failure. And then what is the point of having an implant if you are going to plan for its failure? No. So the only option that is correct is explain that you cannot proceed with implant treatment until the periodontal condition is stable. Understood? So this has to be very clear. You should not proceed no matter how tempting offer the patient gives you to place an implant. What is wrong is wrong. Understood? So very important question. I would say all TMJ questions are very, very important because like I said, they are straightforward, one sure short answer questions. Should not make a mistake if you know, and don't be afraid of such questions. Once you understand the concept, it's very easy to solve these questions, you know, and even you will feel very empowered and very, very confident if you get such a patient in your in your practice, I would say. You'll suddenly be very knowledgeable, you know, in front of the patient. And for the BDS graduates, I'm talking about. So, very good question. Read thoroughly about TMJ after watching my video. Spend like 1 hour or 2 hours. Watch many YouTube videos. Such good videos are there over the YouTube. So do that, and of course study from my both the books, comprehensive ADC book, which has questions from therapeutic guidelines, ODL, infection control, ethics, and study from the Ultimate ADC Companion book, which has from over 25 ADC resource textbooks, basically a question bank for the exam. How will you get those books? Just email me. I've mentioned the email in the link description below this video, and I will email it to you. Alright, so have a nice day. Bye bye.